Welcome to MS Masters, where we present expert lectures on current hot topics in clinical care for multiple sclerosis. In this episode, Jeffrey Cohen, MD, Professor, Cleveland Clinic Lerner College of Medicine, Cleveland, Ohio, provides an overview of the 2024 McDonald Diagnostic criteria for multiple sclerosis, including what's changed, the rationale for updates, and next steps in implementing the recommendations.
Hello, I'm Joe Rusco, Editor-in-Chief of Practical Neurology, and I'm here with Dr. Cohen. Dr. Cohen, please tell us a little bit about yourself.
Well, Joe, thanks for the invitation. So I am a professor of neurology at the Cleveland Clinic, where I hold the Hazel Pryor Hostetler Endowed Chair. I am one of the staff neurologists at the Mellon MS Center, where in addition to seeing patients primarily with multiple sclerosis and other autoimmune disorders, I also direct the experimental therapeutics program.
Excellent, thank you. There's been so much interest about updates to the McDonald Diagnostic criteria for MS. Can you highlight for our audience the main proposed changes to these criteria?
Sure. So I was a member of the 2010 and 2017 international panels. I actually was the co-chair of the 2017 international panel, and then also served on the panel that's developing the 2024 revisions. So there's going to be some substantial changes in the criteria with the new revision. Historically, the McDonald criteria have been based on patients having what's called a clinically isolated syndrome. So that's an attack typical of a multiple sclerosis attack in someone that's not yet known to have MS, or who present with gradual progression. And then to make the diagnosis, so-called dissemination in space or anatomic dissemination, and dissemination in time, in other words, evolution of the disease process over time, needed to be documented. And the McDonald criteria allowed for that to be documented either clinically or by MRI, or more recently by the demonstration of CSF oligoclonal bands. And the criteria defined what was necessary to utilize those tests to fulfill dissemination in space and time. So with the 2024 revision, there are some what I would consider relatively straightforward changes. The optic nerve has been added as a fifth anatomic site to confirm dissemination in space or time. And kappa free light chains in cerebrospinal fluid has been added either to corroborate oligoclonal bands or to replace oligoclonal bands. The advantage being that kappa free light chains are, from a technical point of view, easier to measure. So those are relatively straightforward changes. There also are some recommendations for additional testing in children or with older adults presenting with the question of MS. But then there are what I would consider two relatively substantial changes. The first is some provisions for making the diagnosis not requiring demonstration of dissemination in time. So there was already a change in that direction with the 2017 criteria. The demonstration of oligoclonal bands in CSF could replace the requirement for demonstration of dissemination in time. The 2024 criteria go even further and specify some additional data that can be used instead of dissemination in time. So if there are more lesions on MRI, and particularly if there are what are called central vein lesions, lesions that have a central vein in the center, or what are called paramagnetic rim lesions, which is a very characteristic finding in an MS. So that's more options for making the diagnosis in someone that presents with a clinically isolated syndrome or progression. And then the other big change, and I think this is probably the biggest change, is that there are going to be provisions for making the diagnosis in a patient who has not had a clinically isolated syndrome or progression, but who has symptoms that are common in MS, but not necessarily specific, but they haven't had an attack, or in fact, in patients that have had no symptoms, they just have MRI findings that look like MS that were found incidentally. So that's probably the biggest change in the criteria.
Thanks for that overview. Now, what were some of the drivers or forces behind these changes? Why even update the guidelines from 2017?
Well, with each revision of the McDonald criteria, they've become somewhat more refined, but there was recognition that there still are some patients who are likely to have MS, but for whom the diagnosis cannot be confirmed with the 2017 criteria. So that was one driving force. The second, despite the emphasis on trying to make the diagnosis early in someone who probably has MS, misdiagnosis remains a major problem. It's been estimated that 10 to 20% of people who receive the diagnosis of MS, in fact, don't have the disease. And many of those people get put on disease modifying therapies with the associated cost and potential risk. And then finally, what drove the revision to a very great extent was the accumulation of a sizable amount of new data concerning the optic nerve, central vein lesions, paramagnetic rim lesions, kappa-free light chains. And there was a strong emphasis with this revision for the changes to be data-driven. And so it was the accumulation of that data that really drove the revision.
So, how will these proposed changes affect clinicians? What will they need to do differently?
So when seeing a patient presenting with a typical clinically isolated syndrome or progression typical of MS, the diagnosis can be made the way it was always with the previous criteria. But what these revisions allow is more flexibility. There are different ways of making the diagnosis now in that person. And depending on one's program's expertise and resources, that can be based on new CSF testing, different MRI techniques, optical coherence tomography, OCT, or visual evoked potential. So it gives a lot more flexibility. And then finally, in a patient who's not had an attack, but who does have symptoms of MS that sound like MS or MRI findings that look like MS, there is a way forward to make the diagnosis in that person with some additional care.
Were there any unresolved issues that the panel faced when putting together these updates?
So there was a lot of discussion at the meeting about which things to change and which things did not warrant a change. So the broad outlines of the new revision have been presented at the recent ECTRIMS meeting, but the publication still needs to be finished and submitted for publication. I'm sure there will be a lot of details that need to get worked out at that point. And then once the new criteria are published, they need to be validated in aggregate. There's a lot of data supporting the individual changes, but there aren't very many data supporting the overall criteria in aggregate. So that'll be a lot of work. And the criteria need to be validated in a variety of populations and geographic locations and scenarios. People will need to learn how to implement the criteria from a practical point of view. Each clinician will need to decide what's their typical approach to making the diagnosis using these new criteria. And that'll also entail a lot of education of the clinical community, patients, and regulators, for example, because we use the criteria as the basis for clinical trials. And so there'll be some changes there. I think the main sort of unanswered questions from the panel meeting were different aspects of the optic nerve or the MRI lesion findings in different scenarios. We thought about a lot of different possibilities, but I'm sure things will come up that we didn't think of. And so those scenarios will require more data.
Excellent. Thank you. I saw that ECTRIMS already has a session on the books about implementing these guidelines in practice. So we'll be seeing more things like that. Any final comments?
I would just say that the diagnostic criteria for MS are always going to be a work in progress. We develop new revisions and then we note shortcomings and then we generate data to try to fix those. But it's probably going to evolve over time.
Thank you to Dr. Cohen for sharing his knowledge with our listeners in this episode of MS Masters. And thanks to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the neurology field. MS Masters is brought to you by the editors of Practical Neurology.